Good morning, good afternoon, good evening. Welcome from wherever you are joining us. My name is Julie Rajan, and I'm on the faculty of the Department of Women's Gender and Sexuality Studies at Rutgers University in New Brunswick. And I'm so pleased to welcome you to the second panel, Feminicide and Reproductive Justice, in the panel series entitled Feminicide in Focus, which is this year's theme of the Global 16 Days campaign against gender-based violence. You might know that the campaign was initiated in 1991 by the Center for Women's Global Leadership at Rutgers University in New Brunswick to foster an international feminist movement led by civil society. Each year, feminist organizations globally dedicate 16 days, starting from November 25th, which is the International Day for the Elimination of Violence Against Women, through December 10th, which is Human Rights Day, to address gender-based violence manifesting in their local spaces, for example, through demonstrations and marches, art exhibitions, and digital activism. Since its inception, the 16 Days campaign has established a collective space in which feminists organizing against gender-based violence may strategize, collaborate, and share resources and connections with one another. To date, the campaign is comprised of over 6,000 organizations in 187 countries, and at the international level is recognized by the United Nations, the World Health Organization, among other entities. These collective demonstrations globally during these 16 days every year highlight the degree to which gender-based violence is pervasive in all cultures and throughout all nations globally. Furthermore, they highlight the extent to which gender-based violence is undermining the human security of cisgendered women and girls and members of the LGBT+ community, as this panel will address, to the point of fatality. While the Center for Women's Global Leadership was sunset in 2022, the Global 16 Days campaign remains resilient at Rutgers, New Brunswick. This is evidenced by its widespread support by academic and non-academic units throughout the university. If you would like to join or support the campaign, or would just like to know more about it, please write to the email being dropped in the chat right now. Now, team member Akanksha Bhatter will take just a minute to talk about the continuation of the campaign at Rutgers and provide insight into resources that might be helpful to you in your work.
Thank you, Julie. Good morning, everyone. Good afternoon, good evening. I'm Akanksha Bhatter, a second-year master's student in the Women's Gender and Sexuality Studies department here at Rutgers. Here at Rutgers, under the leadership of Kayo Denda, the head of Marjorie Somers Foster Center and librarian for the Women's Gender and Sexuality Studies, in collaboration with archivists, we are committed to archive CWGL's history and legacy, with particular focus on the 16 Days campaign. This is also an effort to reclaim the campaign, ensuring its roots and history is preserved. Over 70 boxes with CWGL's archival material were sent to special collections and university archives, where they will be organized and preserved. With the ongoing archival research on 16 days, we are also committed to build a comprehensive research guide that's dedicated to the campaign. I encourage you all to check out the library's page on this initiative. As we continue to build this important collaborative project, if there are any materials and resources related to the campaign that you might have that we don't have on the website, please do share them with us. Additionally, as one of the two international graduate students drawn to Rutgers University by CWGL's legacy, my colleague and I started a student-led movement on campus. Over the past 2 years, we have spoken in classrooms, tabled at events, and primarily used social media to spark conversations about the 16 days and gender based violence here at Rutgers. Now, on to the moment we have all been waiting for. Team member Nishi Shah will introduce the panel and the participants.
Thank you, Akanksha, and hello, everyone. I want to thank you for taking the time to join us today from all over the world. My name is Nishi Shah, and I am the program coordinator at the Rutgers Institute for Women's Leadership, where I run different programs and events focused on media and feminism. Prior to this role, I coordinated the Global 16 Days campaign at the Center for Women's Global Leadership. The most recent global campaign conducted by CWGL focused on ending femicide by not only amplifying awareness of what the issue is and how widespread and critical it is, but also by demanding that governments worldwide act urgently to hold perpetrators of all forms of femicide accountable, all while uniting movements and struggles across borders to build solidarity. This Rutgers panel series is a continuation of that multi-year campaign, and I'm so pleased to have experts in the field for today's topic, feminicide and reproductive justice, to share their work with you. This talk will be moderated by Melissa Upreti. Melissa is a globally recognized human rights lawyer, and she served as chair rapporteur and expert member of the UN Working Group on Discrimination Against Women and Girls from 2017 to 2023. And has since joined the International Commission of Jurists as Regional Director for Asia and the Pacific. She was Senior Director of Program and Global Advocacy at the Center for Women's Global Leadership from 2017 to 2022, where she led 2 multi-year Global 16 Days campaigns, including the one on femicide. She is also a graduate of Columbia Law School. Over to you, Melissa.
Yes, thank you so much, Nishi, Julie, Akanksha, and the rest of the team for inviting me to be part of this panel and to moderate the session. Good morning, everyone, and greetings from Nepal, which is where I'm calling in from tonight. As someone who has called New Jersey home for more than 2 decades, and as a former member of the Rutgers University community, which is where I had the privilege of leading the Global 16 Days campaign and working very closely with Nishi and other colleagues at CWGL for 5 years. Let me start tonight's discussion by putting the issue of femicide and its connection to reproductive justice in perspective for you with some facts and statistics from the United States. Women in the United States are more likely to be murdered during pregnancy or soon after childbirth than to die from the 3 leading obstetric causes of maternal death, namely high blood pressure disorders, hemorrhage, or sepsis. While intimate partner violence is common worldwide, with 1 in 3 women reporting experiences of violence, including physical, sexual, or psychological abuse by a partner in their lifetime, studies by experts show that the US has a higher prevalence of lifetime and past year intimate partner violence than other high-income countries, and homicides by an intimate partner in the US are overwhelmingly committed using firearms. It's estimated that in the US, firearms were used in 68% of homicides around the time of pregnancy, between 2008 and 2019, with Black women at substantially higher risk of being killed than white or Hispanic women. Now, not only is the incidence of these killings an issue, but equally concerning is the impunity that follows. Few perpetrators of intimate partner violence, which is a leading precursor to femicide, are ever convicted. This shows that there's rarely any consequence, and there's also no deterrent. Many legal loopholes allowing access to firearms remain. This shows that lawmakers have been negligent in creating the necessary safeguards against femicide, despite the connection between femicide and gun violence being so clear. As noted by experts, and I thoroughly agree, the recent dismantling of women's reproductive rights in the United States, which is alarming in and of itself and could get worse, has created a new urgency to recognize the links between femicide and sexual and reproductive rights and reproductive justice more broadly. While on the one hand, reproductive coercion is a common aspect of intimate partner violence and increases the risk of unintended pregnancy, on the other hand, restricting access to safe and legal abortion endangers women, as unwanted pregnancies potentially amplify risks in abusive relationships. So while culturally, pregnancy is often celebrated and even expected of women, it's actually a dangerous time for women, not only medically speaking, but as potential victims of violence and in extreme cases as targets of femicide. Now, how can we make these realities a basis for legal and policy reform? Well, international legal experts have recognized many different forms of femicide and classified them as direct and indirect based on international human rights law and international standards, as well as women's lived experiences from around the world. Femicide may be direct and perpetrated by an individual, such as in cases of intimate partner violence, or it may result indirectly from systemic discrimination and violence at the hands of a healthcare provider, or at the hands of multiple actors within the healthcare system as a whole who are operating within a certain type of legal and regulatory framework. Leading examples of indirect femicide are pregnancy-related mortality, of which unsafe abortion is a leading cause. And this often happens where there are legal restrictions on abortion or criminal bans, or a prevalence of discriminatory treatment in healthcare settings involving denials or delays in the provision of medical care or the poor quality of care, where socioeconomic status and race or ethnicity are often factors. Globally speaking, 45% or nearly half of unwanted pregnancies end in unsafe abortion. As such, it is a notable cause of femicide that must not be ignored. Now, these are obviously just a handful of statistics and trends, and the expert panelists that we have today will elaborate on many of these issues and more to establish the links. But I do want to highlight a few things which I think these trends illustrate. Number one, femicides are not random acts of violence perpetrated solely by individuals, but these are acts of violence that are often structural. They are rooted in and enabled by harmful gender stereotypes of women, which are embedded in our laws, policies, and practice, and these stereotypes are linked to women's biological capabilities and expected reproductive roles. Femicide is rooted in unequal power relations and manifests in the private and public spheres as a form of control or retribution. Femicide occurs more often than we realize in our communities, although they might not be recorded as such, and these killings are happening with impunity. When we ignore the occurrence of femicide, we ignore a continuum of crimes against women, including specific forms of sexual and reproductive violence and other human rights violations. Femicides are preventable, but legal and societal or cultural safeguards are lacking. Femicide is not only a human rights concern, but a criminal justice issue and a public health issue, among others. With the dismantling of legal protections for reproductive rights, one can reasonably assume that the risk of femicide has increased. The unaffordability of reproductive commodities such as contraceptives, discriminatory and abusive treatment in the provision of healthcare, and deepening gaps in access to services, partly due to misinformation and even disinformation about reproductive and sexual health, all contribute to a higher risk of femicide. In the United States, as the evidence shows, there is a clear link between a woman's reproductive status and femicide. As such, fully recognizing and legally protecting women's and girls' reproductive freedom, autonomy, and rights is a crucial way to help prevent femicide. The absence of such recognition and legal protections allows misogyny and sexism to flourish and creates an environment that is conducive to femicide rather than to a dignified and safe existence for women and girls. This is why, in 2021, while at the Center for Women's Global Leadership, in my role as Senior Director of Program and Global Advocacy, I was very eager to dedicate the Global 16 Days campaign to the theme of ending femicide. As a special procedures mandate holder with the United Nations Human Rights Council, and in my role as chair and member of the Working Group on Discrimination Against Women and Girls, I utilized international human rights law as a basis to push for legal and institutional reform to end femicide as a matter of ending discrimination against women and girls. Today, I am deeply disheartened to see that we live in a world that is less safe for women and girls, with the erosion of their rights, the intensification of conflicts, from South Sudan to Myanmar, where different forms of sexual and reproductive violence are being perpetrated systematically and with impunity, whether as a weapon of war, to suppress political activism, or to humiliate, terrorize, and ethnically cleanse opponents. As noted in a recent report by Physicians for Human Rights on what they have described as a mass influx of cases of sexual violence in Eastern DRC, the Democratic Republic of Congo, many such cases, including those involving horrific gang rapes and the mutilation of women's sexual and reproductive body parts and organs, are underreported because in many instances, the victims are dead. So in order to help us fully understand the links between femicide and reproductive justice, we are joined by three incredible panelists whom I will now introduce. They will make their presentations serially. So our first panelist is Dr. Lila Sharif. Dr. Lila Sharif is a creative writer, researcher, educator, and faculty in the School of Transformation at Arizona State University, where she teaches courses on indigenous ontologies, race, ethnicity, Arab and Muslim experiences in the United States, food studies, global feminisms, and a host of other topics. Her current work conceptualizes Palestinian land, food, and culture through a global feminist, indigenous perspective. She has published essays as well as poetry in academic and public journals. She is a co-founding member of the Critical Refugee Studies Collective and a co-founding steering member of the Palestinian Feminist Collective. Her presentation will focus on reproductive genocide in Gaza. Over to you, Dr. Sharif.
Thank you so much. Just going to share my presentation. What a perfect way to frame this conversation. I'm very grateful to be here. I come to you from home of 22 Native nations here in Southwest United States. And I want to thank Julie, Akshanka, Nishi, and our moderator, Melissa, for putting this incredible event together and just the incredible work that's happening at Rutgers. As feminists, we begin with the premise that genocide is inherently anti-feminist because it is inherently anti-life. And I want to offer a trigger warning. In many cases in this panel, it goes without saying, this is going to be some disturbing content that I will be talking about today. As a form of genocide, reproductive genocide works within the framework of reproductive justice. And broadly speaking, reproductive justice is a framework that upholds the right to bodily autonomy for individuals, families, and communities in all decision-making and practices related to sex and reproduction. Reproductive justice includes the right to have or not have children, the right to give birth in safe conditions, free from oppression, exploitation, and violence, and the right to create and raise families in safe and healthy environments with sustainable access to food, water, electricity, and medical treatment. So what is reproductive genocide, and why did we come up with a term to name the events happening in Gaza? As a form of genocide, reproductive genocide targets the life cycle. It refers to the policies, discourses, and practices that delimit, restrict, target, or diminish the life-giving capacities, choices, access, short-term health, long-term health, and life chances of communities that have been made vulnerable by systemic military violence and occupation, besiegement, settler colonialism, and/or imperial warfare. In the context of Gaza, we have seen reproductive genocide in many ways. It has included the control and cutting off of vital life-giving sources such as water, fuel, and electricity, and food, the denial of life-giving and life-saving medical resources, collective starvation, the murder of elderly men and women, the eradication of entire genealogies. I believe over 900 genealogies have been eradicated in Gaza in the last year. The mass murder of women, the mass murder of children, the mass murder of babies, the murder of pregnant women. These all constitute acts of reproductive genocide that we have seen in Gaza. There were some conditions that led us, and by us, I'm referring to the Palestinian Feminist Collective. We wrote a statement condemning what we were observing as reproductive genocide happening in the Gaza Strip. We first saw a statement from Planned Parenthood that used the very racist and Orientalist discourse of Arab male perpetrators and rapists in order to justify this genocide. In fact, the first line of that statement from Planned Parenthood is Hamas unleashed a brutal attack in Israel, killing over 1,000 civilians, sexually assaulting women and girls, and kidnapping over 200 people, many of whom remain captive. They don't share that many of those people were actually killed by the Israeli military on that day. But more importantly, because these narratives and tropes of Arab masculine perversion and sexual deviance have actually enabled this genocide to be justified. It's in some ways supported manufacturing consent for it. Now, these are based on debunked accounts that circulated and are still circulating even in the US highest forms of governance, from our president's mouth, for example, onto our presidential hopefuls. Now, interestingly enough, it was the state of Israel engaging in sexualized torture, as the United Nations recently termed it. And at the same time, it has gone with impunity. So not only are these acts of violence being perpetrated in mass against women, girls, children, and men, but they're also being justified through a discourse of, again, Arab barbarism. And in fact, a colonel defended the rapists. This is in reference to 9 Israeli military men that raped we believe is a child in detention. And supporters of the rapists actually showed up in droves in order to release them from captivity, from incarceration. And the basis for that was that rape should be allowed because it should, out of an understanding for the hardship endured by warriors, referring to the Israeli military. Reproductive genocide is connected to sexual violence, gendered violence, and sexualized torture. Last week, the United Nations released this report on Israeli treatment of Palestinian hostages in particular. So these are hostages just in the last year that have been taken during this genocide in Gaza and have been tortured in torture camps or are detained indefinitely without any idea where they are. And so these acts include the death of hostages due to torture and rape, sexual abuse, and the torture of women, severe torture, rape, sodomy, and dehumanization of Palestinian men, photographing women in their underwear, kicking and squeezing of genitals, torture if detainee does not do humiliating acts, and interrogation while naked. Now, as Palestinians, we know that these acts are not new. They have been happening for 76 years, but we do identify the sheer mass and systemic upsurge in these practices within the last year. So the point about reproductive genocide is that it aims to destroy life and the promise of life. Its intent is to annihilate indigenous futures. And how does it do this? It does so in many ways. Most notably, immediately following the October 7 attacks, Israel issued collective punishment, a policy of collective punishment, which included forced starvation. So we have 2.3 million people in Gaza that are currently starving while they're being aerially bombed. By November of last year, the average Palestinian in Gaza was surviving on 2 pieces of bread a day due to the aid being completely cut off. By late December, 1 month later last year, Gaza was declared a state of famine. By February of this year, more than a quarter of 2.3 million people in Gaza, which is the highest populated, most dense place in the world, enclave, if you will, in the world, were estimated to be facing catastrophic levels of deprivation and starvation. Now, today, 83% of the people in Gaza require food that does not make it into Gaza. This is up from 34% last year. 50,000 children aged between 6 and 59 months urgently require treatment for malnutrition. Most notably was the Flower Massacre, what came to be known as a series of massacres that began really in February 29th of this year. And this really marked a new phase in Israel's starvation campaign, especially in northern Gaza, which is currently undergoing an extermination campaign by the state of Israel. Israeli infantrymen, snipers, tanks, and drones opened fire on a crowd of starving Palestinians seeking aid in Gaza City as they were lining up to get flour from aid trucks, killing at least 112 and injuring more than 700. Several attacks on Palestinians trying to get aid would have been consistently since this time in what we have collectively come to know as the Flower Massacre. And notably, the Israeli troops were shooting to kill. It was a motivated killing of people that were starving. There's also the systemic attack on the ability to give and receive care in the case of this young man, who many of you may have seen his photo. His name is Shaban Ad-Dalu. He was a 19-year-old engineering student, and he was sick and attached to he was on a hospital bed attached to medical devices when he was burned alive. And his story is quite representative in many cases of the levels of dehumanized forms of systemic violence that are happening that relate to reproductive genocide. So at least 220 UN staff members have also been killed since October 7. And the Gaza Health Ministry reports that over 1,000 Palestinians that are Gazans working in the health sector have also been killed. So it's not just an attack on people, but on the people who take care of them. It's also related to environmental issues, particularly ecocide. Half of the farmlands in Gaza have been completely destroyed. Again, this is not new due to Israel's ongoing assaults and systemic assaults over the years, especially within the last 18 years, while Gaza has been under a siege, a violent siege where Israel controls air, land, and sea. This is a very holy time, a sacred time, I should say, in Palestine, when in October, after the first rainfall, people tend to their olive harvest. The olive harvest is fruit, plant, seed, and food. It's everything. It's medicine. It's something that people use year round. And as you can see in the image on the right, this woman in Gaza's entire farmlands have been destroyed. And on the left, even beyond Gaza, we're seeing in the West Bank, a woman who's 69 years old, these men are carrying her body, was tending to her olive groves when she was shot at by Israeli military. And this is not just limited to the military, but also settlers who are allowed to be armed and who are provided arms by the state. Another point about reproductive genocide important for the context of Gaza is that it is a systemic attack on motherhood. This one young woman who is pregnant says, "I no longer feel the flutter of life inside me. My unborn child already stripped of its innocence and condemned to ruins." This quote really affected me, especially as a Palestinian whose father was born in Gaza. I've never been able to go because of the siege, and also as an expectant mother, seeing these women having to make life in the context of death confronting them in the face has been a deeply traumatizing experience for my community, especially in the last year. Since October 7, reproductive genocide also attacks infants, infanticide. So since October 7, 66,000 babies have been born in Gaza in the context of starvation, aerial bombardment, ground raids, and the dangers of famine and disease continue to grow. Mothers are forced to give birth on the floors of hospitals, in crowded shelters, in restrooms, on the side of the road, in tents. The amazing human rights scholar Noor Arakat posted this story from the Lancet, and this that came out just yesterday or the day before. And the question is, will there be a future for newborns in Gaza? What's going to happen with all of these children? There's also the issue of disproportionate attacks on women's body, spirits, and mental health. What you're looking at here is and this is something that we attribute completely to the creativity of the people of Gaza, which is they've built in the context of their displacement, right? So they're not at the home, they're displaced without any certainty about life tomorrow. But they have built a shelter for divorcees and widows and orphans. And it is the people of Gaza's creativity that will continue to survive this community. The issue for a lot of young girls of reproductive age is the stress of getting your period during a genocide. 700,000 women and girls in Gaza experience menstrual cycles, but don't have adequate access to basic hygiene products like pads. These conditions put women and girls at risk of reproductive and urinary tract infections, and it also has exacerbated mental health issues. One young woman says, the issue is that we're moving around a lot, right? These people are getting displaced from one camp to another without certainty of where safety is. We don't have the luxury of sitting around and relaxing. The UN reported that the Gaza Strip is a graveyard for thousands of children. And more than 17,000 children have been murdered by Israel in the last year. There is an unprecedented number of orphans. At least 17,000 children have lost one or both parents. They've even developed a new category, which is children without any remaining relatives, to address, to name this catastrophe. Now, again, the people of Gaza continue to innovate even when death and destruction are confronting them in the face. They developed another orphanage called Orphanage City, and it's called the Al Baraka Orphanage Camp. This is in southern Gaza. But unfortunately, even these facilities are not immune to Israeli targets and attacks. As one social media commentator writes, Israel defended itself again tonight in the Gaza City, this time against El Amal Orphanage. The targeting of orphanages is a deliberate attack on Palestinian futures, which is part of reproductive genocide. It's also the systemic attack on family. So every day in Gaza, on average, 115 people are killed. That's 1 out of every 55 people living in Gaza. 46 are kids. Every day in Gaza, on average, 266 people are injured with a completely destroyed medical infrastructure. 27 people are buried under the rubble. Over 5,000 people are forced out of their homes every single day. I mentioned that Israel has annihilated entire genealogies, and we try within the Palestinian community to remember their names and keep them in our hearts. One of them is Al-Astal family, and Al Jazeera has a partnership, has a project where they're trying to name these families, these over 900 genealogies that have been destroyed, and providing interactive graphics for you to learn more about these families that have been essentially wiped off. To summarize, reproductive genocide is a systemic attack on life and the living. It's the desecration of life and the living, and it's a targeting of life and the living in order to impact not just the present, but of the future of Indigenous people. Thank you so much.
Thank you very much, Lila, for that very powerful and detailed presentation. I'd like to move us on now to the second panelist, Rebecca Reingold. Rebecca Reingold is an Associate Director at the O'Neill Institute for National and Global Health Law and an Adjunct Professor at Georgetown University Law Center. Her research focuses primarily on reproductive health, rights, and justice in the United States and globally. Reingold previously worked as an Associate Director of the Health and Human Rights Initiative, where she conducted research on health and human rights, sexual and reproductive rights, and violence against women and girls in Latin America and the Caribbean. She currently serves on the Advisory Board of Training in Early Abortion for Comprehensive Healthcare, also known as TEACH. Rebecca's presentation is entitled Reproductive Health Rights and Justice in the U.S. Post-Dobbs. Over to you, Rebecca.
Thank you, Melissa, for the kind introduction, and to the organizers and sponsors of this event for the invitation. It is an honor to join such accomplished experts for this panel. Today, I'll be discussing the current state of reproductive health rights and justice in the U.S. in the wake of the Supreme Court's decision in Dobbs. I will start by providing an overview of the current state of abortion law and policy in the U.S. Then I will share how this new legal landscape is affecting physicians' ability to provide and patients' ability to access essential reproductive health services, with a particular focus on what it means for already marginalized and underserved communities. Finally, I will talk about the utility of relying on international human rights norms, core tenets of the reproductive justice framework, to conceptualize the harms resulting from this new legal landscape, especially given their intersectional nature. Turning to the state of abortion law and policy in the US, 13 states have total abortion bans currently in effect. 6 states have abortion bans with gestational limits at some point in the first trimester, ranging from 6 to 12 weeks of pregnancy. In 2 states, courts have blocked abortion bans, preventing them from going into effect for the time being. While all of these bans contain one or more exceptions, they tend to be quite narrow in scope, both in theory and in practice. Of these 19 states with total or near total abortion bans, 14 contain exceptions for health, but explicitly limit them to apply in situations involving serious threats to physical health. Only 10 have exceptions for pregnancies resulting from rape and/or incest. For now, the majority of abortion bans target physicians. Physicians are subject to harsh civil penalties, criminal punishments, and/or the suspension of medical licenses. Some fines are as high as $10,000, and at least one state imposes a maximum penalty of life imprisonment. A handful of abortion bans also target anyone who aids an abortion seeker in accessing care, which can mean family members, Uber drivers, etc. It is also important to note that even before Dobbs, abortion care was subject to many different types of restrictions at the state level throughout the US. And those restrictions remain in effect today, affecting access both in states with bans and those without them. Examples of these types of restrictions include, among others, restrictions on abortion procedures and medications, restrictions on health professionals and institutions, restrictions on women's and pregnant people's decision-making, and restrictions on funding for and insurance coverage of abortion. Now, I want to take a brief moment to situate this new legal landscape in the US within the broader global context. When you compare abortion law and policy in the US to that of other countries, a few things are notable. First, the abortion bans in effect in some US states are among the harshest in the world. They have some of the narrowest exceptions. Other countries have much broader health exceptions or give significantly more discretion to health providers to interpret and apply those exceptions. They also have some of the harshest penalties for health providers and others who help someone access an abortion. Second, even in US states where abortion is not criminalized, it is accessed in a health system that differs significantly from that of other countries. Many other countries have either universal health coverage or mandatory health insurance programs that create far greater access to health services in general. Abortion is also better integrated into other health systems. And there is more public funding for abortion in other countries. The backsliding that has taken place in the US stands in stark contrast to the global trend towards increasingly liberal abortion laws and greater protections for abortion rights. Over the past 30 years, roughly 60 countries have liberalized their abortion laws. Only 4 countries, including the US, have rolled back the legality of abortion. Now, the consequences of this new legal framework are already proving to be significant. State bans affect access not only to abortion services, but also a range of other essential reproductive health services. Examples include miscarriage management, management of other inevitable pregnancy loss, like ectopic pregnancy or premature labor and previable pregnancies, cancer therapy, and assisted reproductive technologies, just to name a few. The consequences of criminalizing the provision of essential reproductive health services, including abortion care, are far-reaching and felt by both physicians and their patients, as well as their families and broader communities. Physicians are caught between threats of criminalization and ethical obligations to provide their patients with evidence-based care, and have begun to leave states that ban abortion to practice in less restrictive contexts. Training in abortion care has similarly become scarce in states with sweeping bans, exacerbating the OBGYN workforce shortage already looming in the US prior to Dobbs. And the research is already telling us what many experts predicted. The devastating consequences of abortion bans are being felt most acutely in the US by abortion seekers who are already marginalized and underserved. I'm going to touch briefly on how Dobbs is affecting a handful of these groups. First, sweeping abortion bans are disproportionately affecting low-income individuals. Low-income women are more than 5 times as likely to report an unintended pregnancy as women living at or above the federal poverty line, in many cases due to barriers to contraceptive use. As a result, women who are struggling financially have a greater need for abortion. The average cost of a first trimester abortion in the US is $550, and nearly 50% of the monthly income for people living with incomes below the federal poverty line. Even for those abortion seekers who have health insurance, the cost of abortion care could be out of reach due to prohibitions on private insurance and Medicaid covering abortion care. Many residents of states with total or near total abortion bans have to find the cash to cover the cost not only of the procedure, but also travel to other states. Second, total or near total abortion bans disproportionately affect people of color. For example, Black and American Indian and Alaska Native women ages 18 to 49 are more likely than other groups to live in states with abortion bans and restrictions. Many people of color are also more likely to fall below the federal poverty line, be un- or underinsured, lack transportation options, or have paid time off or paid sick leave, all of which affect their ability to travel across state lines to receive care. Post-Dobbs, researchers have found that people of color have experienced the greatest increases in travel time to abortion facilities. State abortion bans are also predicted to increase pregnancy-related deaths, threatening to exacerbate the already significant racial disparities in maternal mortality and morbidity in the US. Third, young people are disproportionately and uniquely affected by abortion bans. More than half of US adolescents ages 13 to 19 now live in a state with severely restricted or no legal abortion access. When minors can overcome legal obstacles to abortion care, such as parental involvement requirements, they can face greater barriers related to cost, information, and access than adults. Yet the consequences of delayed care due to legal obstacles may be more severe for young people, given that they experience serious pregnancy-related complications at a higher rate than adults. While I only have time to mention them briefly, other communities that are disproportionately and uniquely affected by abortion bans can include immigrants, LGBTQ+ folks, and survivors of intimate partner violence, among others. It is also important to note that these groups, even before Dobbs, face the greatest number of practical obstacles and structural barriers in accessing safe abortion services. International human rights bodies have determined that restrictive abortion laws violate a range of human rights, including rights to health, life, privacy, freedom from gender discrimination or gender stereotyping, freedom from gender-based violence, and freedom from ill treatment, among others. I will focus on the human rights contained in the treaties that the US is a party to, which narrows the scope substantially. The US is a party to the International Covenant on Civil and Political Rights, the International Convention on the Elimination of All Forms of Racial Discrimination, and the Convention Against Torture. States' adoption of total or near total abortion bans violate a series of human rights contained within these three treaties, namely the rights to life, privacy, non-discrimination, and freedom from cruel, inhumane, or degrading treatment. To the extent that these bans drive women and girls to seek unsafe abortions or otherwise jeopardize their lives, they constitute a violation of the right to life. They also strip pregnant people of their autonomy, agency, and capacity to make informed decisions about their health and lives, leading to violations of the right to privacy. State abortion bans also force people to carry pregnancies to term under extremely difficult situations, such as when there are significant health risks or following a rape. According to human rights bodies and experts, denying or even delaying abortion care under these circumstances can cause pain and suffering that amounts to cruel, inhumane, or degrading treatment, and as a result, constitutes a violation of the right to be free from that treatment. Finally, the disproportionate impact of state abortion bans on various marginalized groups of women and people who can become pregnant constitutes a clear violation of the right to non-discrimination. The devastating consequences for people of color are particularly pronounced and are expected to only exacerbate already existing disparities in the area of reproductive health for these groups. While there are various limitations associated with relying on international law mechanisms to push back against abortion bans, particularly in the US context, the human rights framework nonetheless offers a powerful narrative to meet this moment. Many of the people who are disproportionately affected by post-obs abortion bans have more than one of the social identities I referenced previously, thereby compounding their experiences of discrimination and marginalization when seeking essential reproductive health services. For example, a pregnant person's income and race can affect the legal risks they may face for accessing care that is criminalized. Both before and after DOBS, pregnant people without access to financial and legal resources are more likely to face criminal repercussions for the outcomes of their pregnancies, including for self-managed abortions. The risk of criminalization, moreover, is heightened for people of color and immigrants who are already disproportionately affected by the criminal justice system in this country. Human rights bodies and experts are beginning to integrate intersectionality into their analysis of human rights violations, as well as their recommendations to states regarding how best to respect, protect, and fulfill human rights. The overturning of Roe has caused and will continue to cause significant harm throughout the US. However, it provides the movement with an opportunity to reimagine and recreate the country's abortion laws in closer alignment with principles of human rights and, in turn, reproductive justice, so that timely, high-quality, essential reproductive health care is meaningfully accessible to all and does not depend on a person's identity, status, or privilege. Thank you, and I look forward to the discussion.
Thank you very much, Rebecca, for that extremely comprehensive and insightful presentation. I would now like to introduce our third and final panelist, Dr. Udodiri Okwandu. Dr. Udodiri Okwandu is a historian of medicine whose scholarship and teaching contextualize profound racial and gender health inequities in the United States. Her current project traces how scientific and socio-cultural understandings of race and motherhood have informed medical understandings of and responses to maternal mental illness. She is currently a presidential postdoctoral fellow in the Department of Women's, Gender, and Sexuality Studies at Rutgers University, New Brunswick. As a presidential scholar at Harvard University, Udodiri earned her PhD and master's in the history of science. Organizations like the American Association for University Women, Institute for Citizens and Scholars, and Consortium for History of Science, Technology, and Medicine have supported her work. Udodiri's presentation is entitled Black Maternal Health, a historic struggle. Over to you, Udodiri.
Thank you so much for having me. I wanted to just thank the organizers for their work in putting this panel together, and to my co-panelists for sharing their critical work. I'm really excited to be part of the conversation. Today, I will be broaching the topic of femicide by examining the current landscape of Black maternal health in the United States and emphasizing how it reflects the longstanding and historical denigration of Black motherhood. As an entry point into this topic, I'm going to begin with some somewhat recent news. So on May 30th, 2024, The Atlantic published an article by Jerusalem Dimsaz titled "The Maternal Mortality Crisis That Didn't Happen," which examined the implications of a recent study that challenged the widely held belief that maternal mortality rates in the United States have sharply risen since the early 2000s. The study in question was conducted by Saloni Datani, a researcher at Our World in Data. Datani found that measurement changes gradually introduced in the US between 2003 and 2017 led to a seemingly steep rise in maternal deaths. Previously, maternal mortality was defined as deaths occurring during childbirth or shortly after. To address past concerns about underreporting, the updated definition now includes deaths during pregnancy and within 6 weeks of pregnancy's end. Additionally, states introduced a checkbox on death certificates to indicate whether a woman had been pregnant at the time of death or within the preceding year. While maternal mortality rates in countries like France, Canada, and the United Kingdom were stable or slightly fell during the same period, reported maternal mortality ratios roughly doubled in the US. According to Datani, while this change helped identify more deaths that meet the criteria for maternal deaths, it also led to some misclassification. In light of this evidence, Dimsaz concludes in her Atlantic article that it's, quote, "time to push back on unwarranted crisis narratives, since reality is scary enough." While these findings may lead some to conclude that maternal mortality rates may be overstated, or that it is critical to produce a more precise definition of maternal deaths, these perspectives personally provide me with little comfort, particularly given the stark racial disparities in maternal mortality in the United States. They serve to obscure the fact that these deaths, overcounted or not, are not evenly distributed across the population. In the United States, Black women face the highest maternal mortality rate. When compared to white women, Black women are nearly 3 times as likely to die, a disparity that transcends education, socioeconomic status, and even pre-existing health conditions. Further, over 80% of these counted deaths are deemed preventable, which means that death could have been avoided by one or more feasible changes to the circumstances of the patient, provider, facility, systems, or community factors that contributed to the death. Besides overlooking the overrepresentation of Black maternal deaths, both the Atlantic article and the Our World in Data study serve as proof of the limitations and omissions that can arise when we define a maternal health crisis solely by the number of women who die during childbirth or during the period of pregnancy. By focusing exclusively on mortality rates, we risk ignoring critical aspects of maternal health and how they also disproportionately impact Black women and grant significant legitimacy to crisis narratives. They constitute what theorist Lauren Berlant calls a slow death, the physical wearing out of a population in a way that points to its deterioration as a defining condition of its experience and historical existence. For example, in comparison to white women, Black women are more than twice as likely to experience severe pregnancy-related complications like preterm birth and life-threatening conditions like preeclampsia. Both mortality and morbidity among Black childbearing women is compounded by the fact that they are most likely to lack private insurance or have discontinuous insurance from preconception to postpartum. Further, nearly 40% of Black women experience maternal mental health symptoms, which is nearly twice the rate of all women, that can lead to ill health, suicide, and even infanticide. Yet nearly half of these women do not receive treatment or support, in part due to barriers with insurance. Finally, in the aftermath of the Supreme Court's overturning of Roe v. Wade, which eliminated the federal constitutional right to abortion, abortion access has emerged as a critical maternal health issue for Black women. 6 in 10 Black women aged 18 to 49 live in a state with abortion bans or restrictions, the highest rate among all racial and ethnic groups. Many of these states do not explicitly have exceptions, which may force women to endure pregnancies that could jeopardize their health. Further, these restrictions have already begun to contribute to obstetric provider shortages and maternal health care deserts, given physician concerns about criminalization. It is estimated that a total abortion ban in the United States would result in a 33% increase in maternal death for Black women. In light of these statistics, I personally refuse to be satisfied with the notion that the state of maternal mortality in the United States isn't that bad. Yet as a historian of race and medicine, I am deeply disturbed, but unfortunately not surprised by these disparities. Undermining Black women's right to motherhood, anti-Black racism, systemic barriers to healthcare access, inadequate support during pregnancy and childbirth, and a pervasive disregard for the experiences and voices of childbearing women have been a feature rather than an aberration in the history of Black maternal health. During slavery, for example, Black women's bodies were commodified and exploited for reproduction, viewed as mere vessels for increasing the enslaved population. This was facilitated by a widespread belief among the white professional medical academy that Black people had inferior, different bodies and psyches, a belief that relied on a denigrated construction of Black womanhood and motherhood. Physicians remarked upon Black women's alleged capacity to endure multiple and painless pregnancies, engage in hard labor, and innate hypersexuality. While gross and misleading stereotypes that continue to persist today, these characterizations were used to distinguish Black women from sensible and civilized white women. A significant consequence of these beliefs was that Black women were denied agency over their own reproductive health, subjected to rampant sexual violence, and marked as the antithesis of domesticity and maternity. In the rare instances in which they did receive medical care, it was to manage and monitor their reproductive lives, including assisting with difficult births, examining the causes of infertility, or investigating cases of infant mortality, all to ensure the reproduction of an enslaved workforce. Further, enslaved Black women were often forced to neglect their own children in order to raise and nurture those of white slaveholders. After emancipation, Black women continued to face systemic barriers in accessing healthcare. The introduction of Jim Crow laws in the South enforced racial segregation, leading to inadequate care in segregated hospitals and clinics, which were often poorly funded and lacked necessary resources. In 1946, the Hill-Burton Act authorized the use of federal funds to build segregated facilities within hospitals, further exacerbating inequities in healthcare. This period also ushered in the eugenics movement, which led to racially targeted forced sterilization initiatives. Black American women were most notably sterilized in southern states. For example, in North Carolina, from 1929 to 1974, 7,600 people who were mostly Black and female were sterilized. These eugenic policies reflected broader societal fears about Black reproduction and were justified by deeply ingrained racial stereotypes that painted Black motherhood as a threat to societal progress and well-being. The legacies of such practices and ideologies continue to be felt today. Black women often face implicit bias and racial discrimination from healthcare providers, leading to delayed diagnoses, inadequate treatment, and the dismissal of their concerns. Black women are also more likely to experience poverty, a lack of access to quality healthcare, and inadequate prenatal and postpartum care. Socioeconomic factors limit their ability to receive timely and comprehensive medical attention, which ultimately increases the risk of complications during and after pregnancy. In addition, social and environmental determinants of health, such as housing instability, food insecurity, and exposure to environmental hazards, disproportionately affect Black women, ultimately exacerbating health risks and contributing to poor maternal outcomes. Ultimately, the struggle for Black maternal health is a historic and ongoing battle against deeply entrenched inequities. Stated plainly, while today's Black maternal health landscape is undeniably in crisis, this state of crisis has, unfortunately, long defined Black maternal health. Now more than ever, it is critical to heed the call of a long lineage of Black women organizers who call for reproductive justice. The human right to maintain personal bodily autonomy, have children, not have children, and parent the children one has in safe and sustainable communities. In 2003, more than 50 Black women's organizations and advocates came together to create a Black reproductive justice policy agenda. In the report, they emphasized that reproductive justice can only be achieved when Black women, girls, and gender-expansive individuals can experience pregnancy and childbirth without endangering their lives. Consequently, they call for critical policy changes, including but not limited to defragmenting the healthcare system, providing monthly financial supplements or universal incomes for low-income birthing people, increasing funding for doulas, robust financial support for pregnancy-related care, and ensuring unrestricted access to abortions and equitable access to effective contraception. These recommendations are essential as they aim to confront the enduring racism, systemic neglect, and disparities in access to knowledge, care, and support that constrain Black birthing experiences. Now more than ever is the time to embrace an expansive understanding of maternal health, to work towards a future where all mothers receive the care and respect they deserve. Thank you so much.
Thank you so much, Udodiri, for another really comprehensive and insightful and powerful presentation. Now, I think with these three presentations, there are many dimensions and aspects relating to the connections that help establish the connections between femicide and reproductive justice have been brought forward. It is time for the Q&A session now, so I'm just looking to see what questions we have received, and I think I'll start with this one. So this is for all three panelists. Perhaps you can take turns answering them. The first one is, if Trump wins the US election next week, how do you suggest we get involved to keep fighting for reproductive rights and for reproductive justice in the United States, perhaps through grassroots movements and actions that connect movements with many of the issues that you have highlighted in your respective presentations? So who would like to go first? I can start with the first panelist. Perhaps Lila, if you would like to share your thoughts in response to
Sure.
that question. Thank you.
So I would suggest that the reproductive health crisis is not contingent on Trump winning the election. We are already there. It is under the Biden administration that this genocide happened in Palestine, in Gaza. So this notion that there is a safer choice when it comes to reproductive health, especially for women of color and particularly for women of color located in the global South, I would suggest that the fight is going to happen either way, and it's a deep, prolonged and protracted fight for reproductive justice. So that means continuing the fight and also naming the violence that we are seeing and bearing witness to.
Thank you, Lila. Rebecca, would you like to share your thoughts? Thanks.
Sure. A couple of thoughts. I think working at the state level has really been one of the effective responses to the overturning of Roe and bringing the issue back to voters as much as possible, since it's not popular to broadly ban abortion and include vague and narrow exceptions. So we've seen ballot initiatives, for example, have quite a bit of success to reestablish the right to abortion at the state level. So I think that work can continue regardless of who our next president may be. Another thing that I think is, and state litigation to support that work as well, grounded in state constitutions, which may have different interpretations according to state Supreme Courts than what we've seen our Supreme Court decide in recent years. The other thing is, and I think the question hinted at this, the power of movement building, that this is, we have seen young people really embrace reproductive justice and link reproductive justice to other social justice movements. And that's something that, looking beyond the US to other countries, has been incredibly successful to move towards the decriminalization of abortion and expand access. Is linking movements and coming together and recognizing the connections between reproductive justice, democracy, rule of law, that all of these issues are connected. So I think continuing to be active in those spaces is important, and probably more so in the context of a Trump presidency.
Yeah,
Thank you, Rebecca. Udodiri, please go.
Yeah, I just want to say I really agree with everything that Rebecca and Lila said, especially the idea that engagement in these issues is not contingent on Trump winning or losing. Roe was overturned under a Democratic administration, even though, Democrats push and make reproductive rights a big aspect of their platform. That's not to say there's not distinctions between how the two parties view those issues, but we can't neglect that fact, that the fight continues regardless who wins. I think the one thing that I would just really add is grassroots organizing. And I think if people have the financial means in order to support nonprofits and advocacy organizations that are really working to support women and connect them to resources, whether it's money to help them travel across state lines, money to get access to contraceptives. I think mutual aid and volunteering is a really, really big thing that people can do, especially if you have the privilege of living in a state that does have access to abortion. And if you have the financial means to support these efforts, I think the work of community organizers has been really critical here. And of course, making a vested interest in electoral politics, not just within the context every 4 years with the presidential election, but thinking about what's happening at the local issue and also at the state level.
Thank you. Another question that I have here for you, which I've received, is, can you talk about the dire impact of a second Trump foreign policy, for example, in terms of the Mexico City policy, global gag rule on the reproductive rights of women in the so-called global South, where we know that access to safe abortion is often a matter of life and death. It's not just, an issue of privacy, but at a practical level. And this is where it also connects back to femicide and the preventable deaths of women. But yes, if the Mexico City policy or global gag rule is reinstated, what kind of outcome do you see, and what can be done then to address the risks associated with that, or the fallout? Lila, maybe we can start with you if you have some thoughts.
Sure. My thoughts are quite similar to the previous question. In this case, we're thinking about what would Trump presidency look like in terms of foreign policy, and what does that mean for the experiences of women and people in reproductive age. And there is not a safe presidential candidate within our two-party system that is going to ensure reproductive health for women of color in particular. So I just want to clarify that applies both domestically and also globally in terms of, Trump's foreign policy. Now, what that might mean specifically for U.S. Mexico border politics and beyond is something that we're already seeing, right? We're seeing it with this administration. We're seeing the caging of children. We've seen it, for an attack on children, an attack on reproduction. We're also seeing how U.S. imperial policies have deeply impacted practices of femicide, such as in El Salvador, where these practices are extremely, unfortunately, quite common. That is not a local problem. That is a global issue. So I absolutely agree that Trump foreign policy is going to be just as dangerous. But again, I hesitate to specify, because, again, the presentation of particular kinds of freedoms within, let's say, the Kamala Harris campaign doesn't falls on deaf ears when we're thinking globally about the Congo, we're thinking about Sudan, we're thinking about Palestine, we're thinking about El Salvador. So, I guess I would just leave that there.
Thank you, Rebecca.
Yeah, so the global gag rule is one of those policies that, at least in recent years, has flip-flopped depending on whether we have a Democratic or a Republican president. And it's virtually certain to flip were Trump to become president. And what that would mean for many NGOs around the world who provide essential sexual and reproductive health services is that they are not allowed to receive US funding, foreign aid, if they not only provide abortions, but counsel, refer, or do any type of advocacy around abortion. So it really affects these NGOs' ability to carry out their work, whether or not it involves abortion care. And it has a serious impact on advocacy efforts around decriminalization of abortion in their own context. Many of these NGOs don't provide abortion services, probably because there are limitations, legal limitations within their own context, but they provide other sexual and reproductive health services like contraception, HIV, AIDS care. And so it is something that will have a huge impact on folks working in the global South in particular, where much of this funding goes. And so, I don't know that there is a great answer to the question of what can be done, because funding for this work, is really reliant in many ways on governments, other countries, supporting these organizations where resources may be scarce in the local context. And so one thing I could offer is, working more with European governments where this type of restriction doesn't tend to change when it comes to a change in the executive branch. And we know that, many European governments provide a great deal of foreign aid to support this type of essential sexual and reproductive health care.
Thank you so much, Rebecca. Udodiri, do you have any thoughts about this?
I don't have much to add to this question. I think Rebecca and Lila.
All right. Thank you. Okay, so now I'm going to go to a question that has, I guess I'll just read it out. It's from a student, someone who identifies as a student, and says, how can we go about bringing this fight to our local communities? Also, how can we bring more attention and research to the barriers that queer, BIPOC queer people face when it comes to reproductive justice and gender affirming care? Is there anyone who would like to take that?
I'll just be brief. I think we learn a lot from abolitionists on ways that you can do care better, if you will. That's not contingent on a top-down approach, a more democratic form of care. Also, care work within community is not something new. It's something that many of us were raised in. It's how many of us grew up and the kinds of worlds that we came in. So I think tapping into the resources, and I don't like to use that word, but tapping into the culture of care that does exist and making that more expansive, I think is one approach to really support people and their reproductive dreams.
Thank you. Do any of the other panelists have a response that they would like to add?
Yeah, I think similar to some of the stuff we talked about earlier is I think getting a sense of what is the landscape within your local community, and if they're identifying if there are already individuals, organizations working in these specific topic areas. More often than not, I mean, if in urban areas is often the case, they often are. But I know in certain other parts within the nation, it might be a little bit harder to have a larger momentum with certain sort of these issues, particularly more like perhaps like rural areas or more geographically isolated communities. So I think tapping into what is already there and seeing what are the best ways that you can contribute to these efforts. I think particularly what this last year has taught me is truly the power of education. Things as simple as hosting reading groups where people can discuss and talk about these issues to gain better understanding. Because I think, oftentimes people can be afraid to admit what they do not know, right? And so rather than, pushing through that ignorance, it might be easier to hide within it, right? So I think education, is a really powerful tool, particularly at the local level. And yeah, I think those are two of the key things that I would just spotlight.
Great. Thank you.
No,
Rebecca?
I
see.
I
No.
whole no, I have a couple things just to add, but also wanted to say I completely agree with what my co-panelists have provided. I just wanted to say that I think storytelling, which can reduce stigma around some of these essential reproductive health services that are now criminalized, can be a powerful tool to change hearts and minds, and particularly storytelling within communities, so that the story you're hearing is from your neighbor, from your family member. I mean, it's accessible because I think we know and trust the people closest to us, and that can be a powerful way to bring people to an issue that they may not have had on their radar or felt like affected them personally previously. And then related to the attacks on gender affirming care and linking movements, reproductive justice, and bringing that together with all the folks working to advance LGBTQ plus rights in this country. I think there's a huge urgency to that work because we have a case currently before the US Supreme Court that is looking at a ban on gender affirming care for minors. And I think again, storytelling around this, around families who are affected by this. In many cases, families want to support their kids in accessing this care, and many people could relate to that story once you talk about it as part of a family's decision and wanting to support their kids. But I know with the political sound bites we get, that's not how it's talked about. So I do think there's urgency there. We could see some things come down from the court, this year that really affect access to gender affirming care.
Thank you, Rebecca. So yeah, we have lots of questions coming in now. Additional questions. So there's one where there's a bit of a comment, but also a question, which goes, I deeply mourn the tragic loss of life and suffering in Gaza and oppose any form of violence targeting civilians. However, I've also seen some people frame the horrific acts on October 7th, including the rape and murder of Israeli women, as justified resistance. With such brutal acts being committed, can we really justify any of it, no matter the cause? Lila, would you like to take that one? Yeah.
Yes, it's going to be a brief response. In general, I won't participate in any racist kinds of discourse that, for the reasons that I mentioned in my presentation, that would justify in their language or in their trope a genocide. So that's my response to that question. Thank you.
Thank you. There's now a question specifically for Rebecca and the Dobbs case. It goes, could the Dobbs case realistically jeopardize the right to contraceptives and other rights to privacy and reproductive rights, considering Justice Alito brought up the reevaluation of due process cases like Griswold? Also, could the setting of fire to ballot boxes recently be a form of violence against women, as well as an obvious threat to democracy? Did that actually happen? Setting fire to ballot boxes? Yeah. I've been out of the country for a while, so wow. Okay, yes. Then Rebecca, please. Respond.
So in response to the first question, yes, from the day Dobbs came down, my concern was that the reasoning relied upon by the majority is one that could very easily extend to the right to contraception. The justices attempt to distinguish abortion from contraception and other rights that are protected under the Due Process Clause by saying that potential life is involved in an abortion, but not in the others. However, as we've seen in cases involving IVF and the fetal personhood movement's approach to when life begins, we know that the most radical contingents of the Republican Party see life beginning well before you have a fetus, for example. We're not just talking about the fetal personhood movement, we're talking about a prenatal personhood movement. And so the logical extension of that is that certain forms of contraception may be up for debate. Justice Thomas certainly throws out this idea that other rights under the Due Process Clause, were the right case to come before him, at least, he is open to rolling those back as well. How other justices on the court see it is a little less clear, but I think we should be concerned and prepared. In terms of the voting, the fires set to destroy voting centers and ballots, et cetera. I think it's an interesting question that probably academics have engaged in, what exactly constitutes violence and what exactly constitutes violence against women, because we know that there are many institutional, structural forms of violence that exist, and this likely falls into that category. But whether we want to say that it constitutes a form of violence against women, I think would be a bit more complicated, because if we start calling structural violence interpersonal violence, there's the risk of conflation, and it may have the effect of, if you call everything violence, what does that mean for the most egregious forms of interpersonal violence that we really want to be able to name as something very severe and harmful? So I'll stop there. I'm interested to hear what my co-panelists may think.
Thank you. Would anyone like to add to that? We can move on. Okay. So another question that we have received is, how do any of the panelists reflect on the neoliberal transformation of state and society that has not only hollowed out the social institutions of reproductive rights, for example, privatization of education and healthcare, but also pushed the responsibility of pursuing justice on an individual level? How are we to build a united front of communities spread across racial, class, geographic, etc. lines? Would anyone like to take that? Lila, I see you nodding. Yeah.
Yes, I would just reiterate something my co-panelist Rebecca said, which is the importance of storytelling and story sharing in spaces of safety. So when I'm thinking about storytelling, I mean in a way that people's are protected and feel that the space protects them. A lot of times we are called upon to give visibility to our personal experiences without the protection, without the safety. So I would say that step one is to create spaces of safety for storytelling and story sharing around reproductive, maternal, and other forms of health that concern women of reproductive age. And that would just be like a very baseline starting point.
Thank you. Udodiri?
Yeah, I think I'll just jump in to say that, yeah, it's undeniable that there's many ways in which, our nation touts itself as a space of democracy, of equal rights, of serving the interests of the people. And I think we've seen time and time again, particularly in light of discourses around this election, that the interests of capitalists, the interests of those in power, those it's most privileged, are disproportionately supported, enabled, and abetted by our government. And so I think, given so many of the discussions happening, particularly around the vote right, many people see it as a time to divest from the system, which I think are completely understandably right. But also I think on the other hand, we know that it's one of the few means by which we as a people have any quote unquote say in what is happening within our democracy. And so I don't undermine the complexity of this moment and what it's also revealed. But I think what it does really show is that like true radical change, we can't necessarily rely on these systems to do that for us. Time and time again, we've seen in most past civil rights movements that have pushed across this nation from the 1960s to preceding that, from the Black Lives Matter, that has been the people. That has been the people organizing, collaborating, working together, and calling the government on its BS. I'm not going to curse on the panel, but calling attention to the limitations of the government. And I think that is where a lot of our efforts really need to be going to this point of storytelling that Lily just pointed out. How do we kind of recognize, rather than continuing to engage in, I think, divisive politics that I think can further serve to disconnect us, thinking about, how can we actually create broader solidarity networks between us to understand who and what it actually is that we are fighting. How can we actually, push towards a system, push towards a state in which we have more choice, we have more options, where we're not so reliant on, a two-party system that in many ways is failing the needs of both sides of people who are committed to pursuing both democratic and Republican ideals. I mean, I don't think that should be a controversial statement that they've failed the U.S. and the citizenry in so many different ways. And so I think it's really getting clear on the fact that like it's not your fellow individual neighbor that is the reason why you might not be able to pay for groceries or buy rent or pay for, afford your rent or buy your groceries or get an abortion. It is the concerted efforts and neglect of our elected leaders failing to put the needs of the people at the heart of it. And how can we as a people better collaborate, work together to not only identify the root of the problem, but also resist the problem. That's what I would have to say about that.
Thank you. So another question that has come in for any panelist who would like to take it is, what role does the concept of necropolitics and colonialism play in the devaluation of Black women and Palestinians in Gaza regarding reproductive genocide?
So I can speak to this. I think it's a really good question. Thank you for asking. I think necropolitics is a helpful framework. I think it comes within a broader umbrella of dehumanization that we have seen quite literally imposed on the bodies of Black women in this country, as well as women in the global South, Indigenous women as well. So I think this dehumanization is important because it must be contextualized within a broader history of imperialism, chattel slavery, settler colonialism, incarceration, mass incarceration, the war economy. These deliberately, directly impact the lives of women. So is it useful to think about this in terms of a necropolitical framing? Perhaps. Absolutely can be theorized as such, and many people have done that important work. But I also find that necropolitical can sometimes be a little stifling, because wherever women are, they often regenerate life, and they do so creatively as problem solvers, as a matter of survival. So I find that it's this moment has revealed that we live, and I think women of color in particular, live in a liminal space between the necropolitical and the everyday work to sustain and generate life. And that does situate really well within this umbrella of a long array of colonizing women's bodies and dehumanization, and historical context becomes extremely important.
Thank you, Lila. Would anyone else like to add to that, or should we move to the next question? All right. So the next question is, if I am giving SRE in the local schools, how would I introduce the abortion and reproductive rights to teenagers if I want to destigmatize abortion and empower young girls?
I can start and say that there are a
Mhm.
lot of experts around the world in the US who work on this and have a ton of resources that would likely be useful. So what I may do is put a couple in the chat. There are some folks who think about this very much from a US perspective, what's right for the US context. And at various stages, starting from a young age through high school, that I think, the early you start, the better, and what information's included is dependent on, what age kids you're speaking with. And then at the international level, International Planned Parenthood has done a ton of work on integrating human rights principles around comprehensive sexuality education into national laws. So I think both could be great resources that could support the really important work that you're doing. So I'll drop some links in the chat shortly.
Great. Thank you so much, Rebecca. Another question that we have received is, I would like to ask all panelists to address the ICJ, International Court of Justice's decision that found that Israel is plausibly committing genocide in Gaza, in part through targeting reproduction and women's bodies. How is domestic policy linked to foreign policy in the context of American empire and our collective responsibility for genocide? As a continuation of this question, the person asks, particularly as American empire starts at home and indigenous women's reproductive and ability to mother or parent has been targeted in the US as a form of genocide. Yes, so if someone would like to take that. Lila?
Yes.
Yes.
I hope I have a coherent thought. I'm going to give it a shot. So the question starts to asking about South Africa's case of genocide against the state of Israel. What's really compelling about that case, if anybody has taken a look at it, which was recently updated into, I think, a thousands-page document just this week. One of the fascinating aspects of it is, if you look at the case itself, one of the most challenging things about genocide is to prove intent, right? That is where it becomes very challenging to accuse or to take people to court. But what we find in South Africa's case is that at least a third of their document has Israeli officials declaring intent, not just genocide, but extermination. We're seeing that play out in real time in northern Gaza, particularly in Jabalia, where in the last 10 days, they've killed over 1,000 people who are displaced in camps. They've also bombed an orphanage. So the connection between the domestic and the foreign is one that cannot be understated. In fact, when Udodiri was speaking, all I could think of was reproductive genocide is a form of eugenics, right? It's an act of extermination, and it's an attack on the future, which, becomes really expansive when we return to the previous question about how do we create communities of solidarity that are international, local and global, attentive to women in the global South as well as the so-called global North. And increasingly, it appears that our struggles are deeply linked. The dehumanization of women, of Black women, of Indigenous women here in the United States, of migrant women, of refugee women, directly as a result of colonialism and empire, is a foreign policy. And we see it playing out in Israel, at least in a very localized context, where Israel has engaged in eugenics practices against Ethiopian refugee Jews seeking a citizenship or legal residency in the state of Israel. So with that in mind, I just don't think we can think about these things separately. The local is global and the global is local. These are the same phenomenon that sort of become imposed on the body, right? So again, that is something very challenging to think about, but it also makes our solidarity more urgent and more expansive. And that is the work that I'm dedicated to, and that I am constantly trying to think about, right? How do we have a borderless feminism that looks at women in these different locations and respects their life, right? That is the question.
Thank you. Would any of the other panelists like to comment or add anything?
I think I'll just say that, Lila, I think you articulated it perfectly and comprehensively. But yeah, I think just a small thing to add is, yeah, I think we do have this idea that we can kind of split what happens at home versus what's happening abroad, that these two things are disconnected, when in reality the same logics that are perpetuating and naturalizing the killing of Palestinian people and reproductive genocides are happening abroad are disconnected from attacks on, reproductive autonomy, lack of these are two, they're enabled by the same logics, even if their expression are different manifestations of violence within these contexts. And so again, I think when we put it within that framework and recognize that our struggles are interconnected, if anything, to Lila's point, it should be pushing more solidarity between a range of groups rather than divisiveness or attempting to construct these things as distinct or an exception or something that can easily be ignored. Which again, I think which is why this moment is so maybe appears more complex for people, because it's easier to separate them in order to justify particular modes of action. But that's all I would want to add.
Thank you. Okay, so we do have time for one last question, just about 2 minutes in total. I think with the elections next week, there's quite a bit of anxiety around that, and a number of our questions have been related to that. But this one specifically goes like this. Like many activists I know, we are all conflicted on voting towards someone that does not seek to liberate the Palestinian people and put an end to the ongoing genocide. However, we also know that having Trump in office again would be devastating. However, voting for a candidate like Jill Stein, a third party, as nice as that would sound in theory, is not a possibility in the two-party system we live in. Do I try to talk to and convince people to vote blue, or is voting for a third party actually a valid option? Since this was asked, I just wanted to put it before the panelists in case anyone would like to respond to that before we start to close this webinar.
This is a really complex question, and we do have a very historic election, if you will. We say this every election, but this one feels really historic in my body, to be honest with you. And on the one hand, I understand that we need to maneuver within this two-party system in order to get the best gains for ourselves. I see this discourse circulating everywhere about how we need to vote for the lesser of two evils and et cetera. But at the same time, voting for the lesser of two evils is still voting for evil. So I don't have an answer, but I do understand the complexity of this particular condition that we're in. On the one hand, we have seen what Donald Trump has done to between the Muslim ban and the attack on the Black body in the entire presidency, Muslims, Arab peoples. And we've also seen a genocide, here. We've seen absolutely nothing to overturn the Roe v. Wade in the last 4 years as well. So, I think that we are going to have to deal with some really heavy stuff with this election. That's all I can really say about that.
Thank you. Okay, well, I really appreciate all of you answering the questions that were put before you. Thank you so much. And I think we've done very well with time. So as we begin to wrap up this webinar, I would like to give each one of you a minute to just share any final thoughts regarding the topic of femicide and the connections with reproductive justice. So perhaps I can start this time in reverse order with Udodiri. Then, could you please in a minute just sum up any final thoughts that you have?
Yeah, I don't have too much more to add. I think I just want to really thank my panelists for their presentations. I think if anything that I've really taken away from this conversation and the questions we've had is that really thinking about the interconnectedness of struggle is really important. Thinking about reproductive justice and the concept of feminicide as either a domestic or a foreign policy issue rather than one that is deeply entangled within one another is, I think, really key, because I think it not only is a critical aspect for building solidarity networks, but also recognizing the ways in which we can better mutually support and work towards shifting the systems in which we exist. I also think something that's really important for people to take away is to think about what constitutes violence, what constitutes death, and that it's not simply, while important, is not simply the material end of life, but also thinking about the ways in which systems and structures and policies continuously denigrate life, which is often disproportionately people of color, low-income people, and those abroad deemed inhuman or not worthy of the full vitality and beauty of life. And so I think just a really big plug for the recognition that reproductive rights is a human rights issue. And I hope that this political moment is not just a moment, but one that really rallies people and pushes them to continue to challenge the systems within they exist in and demand more.
Thank you. Rebecca?
That really aligns with what I was reflecting on as well through the conversation and the presentations. A lot of my work recently has been thinking about how we here in the US can learn from the experiences of other countries, which is not a place many Americans often find themselves. But I think in this moment, it's particularly important, whether we're talking about access to abortion care, democracy, the interconnected nature of the various challenges we're facing in this world. And so I would just say that when it comes to abortion, there are many countries who have lived through incredibly draconian restrictive abortion laws and movements that have responded with immense creativity and perseverance and persistence to get to the small incremental wins that have been very meaningful for the folks within their borders. And that same sentiment can be applied to, we can look elsewhere for many ideas about how we do democracy. We can move beyond a two-party system. We can look at other ways that health systems are structured. These are big, big changes to our systems and institutions, but there are other ways of doing things. And I think now is a really important moment to really push ourselves to be open to that and think long-term about how to move towards that.
Thank you, Rebecca. Lila?
Yes, I just want to also express gratitude to my co-panelists for their work and their presentations, and also to you, Melissa, for being such a gracious facilitator. I would only add one point is that, women, however defined that category, have never been passive receptacles of violence, and we've always been rising up. And I think the goal and the motivation could be to really support that work that is happening at the grassroots level, as a way to really, really steer change in a way that is beyond the moment, as Udodiri said, and really rises to a really decolonial vision for what care can look like and what families can live, how families can live. And thank you for this invitation in this wonderful space.
Thank you, Lila. And yes, thanks to all of you for really sharing your wisdom and your knowledge and your insights. I feel like you've helped us all sort of come together intellectually around many of the issues that were discussed today, and hopefully energized a lot of people to really think about how to apply what has been heard. So it was a great honor for me to moderate this panel. I'd like to thank all of you and of course the organizers. And with that, hand the floor back to Julie.
So please join me in thanking Melissa, Lila, Rebecca, and Udodiri for a really dynamic, highly critical conversation. I also want to give a special shout out to Dr. Rosalind Pacheski, who was very helpful in the development of this panel, and of course to my team, Nishi Shah and Akanksha Bhatter. And finally, we also thank you, our audience, for taking the time to join us this morning.